Thank you, Mr. Chairman. Thank you, Dr. McCance-Katz. We are very excited that you are doing fantastic work in this position. You've got a lot on your plate, but we're excited about some of the early deliverables. I wanted to maybe first ask you to talk a little bit more about this question of integration, and you referenced it in your testimony, but I'd like you to talk a little bit more about the work that can be done at HHS and through CMS to try to bring together our behavioral health system and the rest of our healthcare system. Whether the proper ways to do that are working through state governments, whether there are new payment mechanisms that we could develop through CMS to try to marry together these systems. It's an anachronism, the idea that we have one system of healthcare for your neck down, and then you have to walk across town to find somebody that will treat the rest of your body. And it's a slow progression to fix that, in part because of the way that we fund mental health and mental health services. So there's at least one grant program at SAMHSA that's designed to take this on, but tell me what you've been doing since you've been in the job to try to promote integration.
Yes, so thank you for that question, because I think we're doing a fair amount. So we have funded programs that are bidirectional, and that was through the Cures Act, so that behavioral health care can be put into primary care settings and primary care into behavioral health settings. We also have a program that, again, Congress brought into being a couple of years ago and is now in the process of implementation, and that is for the Certified Community Behavioral Health Centers. These are programs that are focused on behavioral health care, but require that both serious mental illness treatment and substance use disorder treatment, as well as physical health care, can be in the same setting for individuals primarily diagnosed with mental disorders. So that's very important. We work collaboratively with CMS. We are talking with them about what kinds of innovations they might be able to look at in terms of ongoing funding. I will personally advocate for the continuation of the CCBHC, the Community Behavioral Health Center program, because even though we have an evaluation out, we know that FQHCs work very well, and they work very well because they integrate care, and they pay for that care. And that's the other thing about the CCBHCs. We have CMS that is providing the payment for services. I think that's going to be very important to establishing these kinds of centers. We also work collaboratively at SAMHSA with other operating divisions that provide direct care, including HRSA, which is a much larger organization than we are, but we provide a lot of technical assistance and opportunities for training for their providers on behavioral health issues. Same with Indian Health Service. And I have also, since I started, had my chief medical officers establish a relationship both with HRSA and the Indian Health Service to make sure that these things move forward.
You know, often states regulate behavioral health care centers and their primary care or federally qualified health care centers through different agencies. And so when they try to combine, they often have some just simple regulatory hurdles, like, you know, the number of fire drills are different in the two different locations. So when they go onto one site, they often are sort of being over-regulated. And so I hope that that's something that you'll help states try to overcome. One final question on HIPAA. I mentioned it in my testimony. A lot of confusion out there in the community as to what clinicians can share with family members, with caregivers, and we gave you the ability to develop some new guidance to try to make it clearer, I think mostly to providers, about when they are actually able to share information with a mom or a dad or a caregiver. I know you're working with the Office of Civil Rights within HHS on guidance, but just wanted you to give us an update on when we might be seeing that come forward. I think it'd be really helpful to everybody in the community.
Yes, I can definitely comment on that. For one thing, I think today you will get a series of informational documents from the Office of Civil Rights that further clarify when information can be shared. We spoke about that. I spoke with them actually yesterday at HHS about it, so they told me that would be delivered to Congress today, just as our ISMIC report is coming to you today. A few weeks ago, the Office of Civil Rights put out a guidance to practitioners about what can be shared in emergency settings. So one of the big sources of confusion has been when a person comes into an emergency department, for example, with an opioid overdose, can that information be shared with caregivers, with loved ones? And the answer to, and often has not been shared because mistakenly practitioners think this is covered by 42 CFR, the federal confidentiality statutes related to substance abuse treatment. This is not substance abuse treatment. This is treatment of a medical emergency, and under HIPAA we are able to share that. But also, it's also true that there are exceptions under 42 CFR. And so we have had one guidance go out to practitioners about what they can share under emergency situations. That went out in November. We are working on another document that will further clarify both HIPAA and 42 CFR in the same document. I like these to be short and easily digested by practitioners. I can tell you just last week I was at a national meeting of substance abuse treatment providers, and the issue of sharing information was one of their main issues. And so I am really grateful to Congress for the direction on this.
Thank you for taking it so seriously.